Now it says pause recording.
It's unpaused now.
It's unpaused, okay. Good morning, everyone. I have an hour to tell you more than you ever wanted to know about Pedi Neuro. And this is building on what you've already had. You've had adult neuro before your first exam. You had a great lecture on musculoskeletal today. Some of this may be repetitive, but that's okay. If you're like me with the cranial nerves, the more you hear them, the better it probably is. Okay, Sandy, my clicker isn't working. Sandy, my clicker is not working. Did I do something wrong?
I just used the keys.
Yeah, the keyboard's not working either. I broke it.
Did you break it again? This one?
No, the one that was in the box.
It's probably in the box. Let's try it. They may be out of batteries.
Sorry about that. We were ready.
Okay, let me do this to the stair rack clip down. Oh, you're going to have to use this one, your mouse. Because you did a PDF, so you have to do it a little differently.
Oh, okay.
And just hit right there on that arrow.
Okay, thank you. Live and learn. I put the objectives. This slide presentation is up. And for those of you that complained last time that I did not tweak it anymore after I put it up. So we're all talking from the same set of slides. And I'm going to start with embryological development because I think it's so fascinating to know when these defects occur, how early they occur. So I'm going to talk about a few main things that would be useful for you to know. The CNS, central nervous system, is one of the earliest systems to begin development, and it's one of the last systems to reach maturity. I mean, you probably know adults that are still maturing. There's development. The development of the CNS is divided into 6 stages. I'm only going to discuss 3. Neurulation, organization, and myelinization. All of these stages overlap. Development progresses at different rates in various parts of the central nervous system. Why do you need to know this? I'll tell you. At 18 days gestation, the central nervous system arises as a thickening on the dorsal portion of the embryo. Remember, the embryo is only about as big as a speck. So 18 days old, they're already starting to develop their central nervous system. By 24 days of gestation, fusion of the cranial portion forms the forebrain. If failure occurs in this stage, you're going to have an anencephalic infant. So this is 24 days into the pregnancy. 26 days, 2 days later, the fusion of the caudal end occurs. If failure happens here, you're going to end up with neural tube defect. Spinal bifidas, myelomeningocele, whatever. This is a picture that shows the formation of the spinal cord. This is 21 days. This is the head end. This is the back. This is the tail end. At 22 days, when it starts to fuse, and then at 28 days, and this is where you can see a spina bifida has occurred because it didn't completely fuse. This is, of course, obviously a picture of an anencephalic infant. And then the one in the bottom corner here is the spina bifida.
Turn the slides off so I can see better up here. It's hard to see that.
Organization. The peak period for organization of the central nervous system is about the 5th month of gestation for 20 weeks. And it occurs up to 1 year of age, but it can continue for many years after birth. This allows the nervous system to operate as an integrated whole. Have you ever seen a disorganized infant? They just can't get it together. You know, infants' movements should usually be smooth and kind of all together. If they have a moro, it should happen symmetrically. If they're disorganized, you're not going to see that. Some processes, such as synaptogenesis, continue until death. You are engaged in the process of synaptogenesis in this class. You're learning new skills, new techniques, and as you practice them, they're going to get easier and easier for you, right? I learned synaptogenesis when I learned to play the pipe organ. I was so proud when I could play the pedals and the keyboard and not fall off into the pedals. That was synaptogenesis. I was learning new things. Brain plasticity in infants is a very interesting thing. When neuronal processes are targeted for elimination, and then they go through cell death, in an infant, these can be saved if needed to replace damaged areas, so it preserves functional ability. That's a really neat thing if you see babies with damage at birth. There is always a possibility that they can recover. So you always hold out that hope for the parents, depending on what's going on with them. Cause of disruption in organization is prematurity, insults from errors of metabolism, abnormal chromosomes, and perinatal insults. If you have failure in this stage, you have an infant or a child who's extremely hypersensitive, poorly modulated behavior. They have all or nothing responses. You see this in the trisomies, Down syndrome, trisomy 13, 14, 15. You see it in PKU and especially in Fragile X. When I think of disorders of organization, I think of Fragile X because they tend to have an all or nothing response. And I'm not going to spend a lot of time on these. This is a trisomy 13. Are you familiar with these? If you are, I'll move on. Trisomy 13, typical faces, low set ears. They have cleft lip and palate. They have a short chest. Look at the fisting, and I'll talk a little bit more about fisting later. That's typical in this. Trisomy 18, they have a shield chest, kind of a short and flattened sternum. Again, the low set ears. They have a prominent occiput. You call it shelving. The occiput actually kind of ends in a shelf. It's just a real abrupt ending to it. They also have a typical fisting. I can't do it, but their middle fingers are kind of together like this, and then their other fingers fold over, and they have this fisting with their thumb on the inside, sometimes on the outside. But if you have a chance to see this, look at these features. Trisomy 18 also has what's known as rocker bottom feet. If you look at their feet, instead of being flat, they're like a rocker bottom, a prominent heel, and it curves that way. Everyone knows our little friend with Down syndrome. I mean, you can show this picture to anyone and they will know this is Down syndrome. What do you see? The hypertelorism, the low set ears. The protruding tongue is very typical in kids with Down syndrome. They have excessive neck tissue, neck fold. And the thing about Down syndrome, you may see this, I don't know, on a test. They also are prone to have a third fontanelle. And I'll talk about that in a minute. Myelinization, this is development of the myelin sheaths around the nerve fibers in the central nervous system and the peripheral nervous system. What does this mean? This just means that it sheaths the nerve. And this comes up, do babies really feel pain because their nerves aren't completely myelinized? Yeah, they do. It's not perfect, but they feel it. By 30 weeks gestation, this is complete in the ascending pathways in the spinal cord, the brainstem, and the thalamus. By 37 weeks gestation, it's completed from the thalamus to the cortex. If you have disorders of myelination, it can be caused by malnutrition, by hypothyroidism, maple syrup urine disease, PKU, homocystinuria, and things like that. And PKU and maple syrup urine disease, I just put up here. This is probably more interesting for the Pedi students. PKU is something that we test on our state screens. If it comes back abnormal, they need to be treated, and that's beyond the scope of this course. But if it's not treated in the first 3 months of life, these babies are going to end up with profound mental retardation that's irreversible. And this is very easily treated with diet. The PKU kids generally are fair-complected, blonde hair, and blue eyes. So they just are very fair-complected. Maple syrup urine disease, Appearance isn't so abnormal, but again, it's an enzyme problem, and their urine smells like maple syrup. It's also managed by diet. If the diet isn't followed, then they can also have profound mental retardation. Remember, when we're doing assessment, a thorough history is the most important tool that we have to accurately diagnose anything, neuro disorders we're talking about today. When you get the chief complaint in the history of the present illness, this should clearly tell you what's going on, the timeline of what's going on, and the sequence of the neuro symptoms. A detailed history is going to determine if the neuro symptoms are acute or chronic, static or progressive, recurrent or monophasic, periodic or random, short or prolonged. You also want to know what causes them, what eases them, or what changes them. History and review of illnesses is going to provide your background information about the patient and may give you an idea of a more generalized disorder or predisposing condition. Family history can provide clues for underlying genetic hereditary things. You know, we always say fruit don't fall far from the tree. So look at the parents, look at the grandparents, and see if there's something significant there. Social history, especially with kids. How are these symptoms affecting the patient and the family's day-to-day living? The kid's school performance and quality of life. What impact is it having on them? And the developmental history may provide you really early clues of a degenerative disorder. When you're dealing with kids, you don't just ask their history, you have to know mom's history. So what kind of risk factors were present in the maternal history, OB, and the neonatal histories? Were there neurotube defects? Were there chromosomal genetic abnormalities, other malformations? Did mom use drugs? Did she have chronic maternal health problems? What's her age? Extremely young and extremely older moms tend to have more problems. And you OB people, what is the age for an elderly primate? 40-something? 35? Isn't that disgusting? Yeah, I mean, you're labeled as an elderly primate if you come in at 35 with your first baby. What's the mom's nutritional status? We now know that folic acid is very important to prevent neurotube defects. And we also know that nutritional status in women is important from the get-go. So you have a child growing up, what is their diet? And then when they get older to have babies, because of continued poor nutritional status, they're going to have problems with their babies. Have they been exposed to teratogens? And what was the outcome of their previous pregnancies? OB history, you want to know gestation. Were there any placental problems, abruption or previa? What kind of analgesia or anesthesia did they use? Was there any infection? Was the baby large for gestational age? You know, that's like a cork in a bottle. They're hard to get out. They tend to have birth injuries. What was labor like? Was it prolonged? You get a report of 36, 48-hour labor. That's a long time. Or was it precipitous? Did she come in and, boom, deliver on the gurney up to the floor in the elevator? Did they use forceps? Was there an abnormal presentation? Any kind of fetal distress, hypoxia, or low APGAR scores are all significant. Baby gets to the nursery. Did he require resuscitation? What were APGARs? Hypoxic episodes, shock, hemorrhage, infection, congenital anomalies, anything abnormal in this neonatal period. If you get some of our graduates, I'll apologize in advance, but you want to know that neonatal history. These are probably going to be babies with problems. Chronic lung disease, neuro disease, you name it, we'll ship it on to you. When you're doing a physical exam for these newborns, neonates, you want the height, the weight. OFC is the head circumference, occipital frontal circumference, blood pressure, and heart rate. What does the baby look like generally? Remember, I keep saying this. You can do more than 60% of your exam by just inspecting, just looking. What's the general appearance? Are they alert? Are they attentive? Are they lethargic? Are they sleeping? Are they out of it? What kind of spontaneous activity do they have? What is their response to light, to noise, and to touch? Are they readily responsive? After the first few hours of delivery, after they've been born, they're going to go into a deep sleep for 12 hours. And they're going to be pretty much unresponsive. So if you do a neuro exam during this time, it's going to be abnormal. You have to wait until they wake up. Look for any dysmorphic features of the face, the head, the ears, the trunk, the extremities, or the digits. You know, we all know what normal looks like, and if we see someone that looks a little bit different, we're going to tune in on that, right? You stood in line at the post office or at the airport and watched people? Lots of fun. Look for discolored patches of skin, such as hemangiomas or cafe au lait spots. Look for their fontanelles. First of all, do they have any? Remember, newborn after vaginal delivery is going to have overriding sutures. The fontanelles may be very small, but they should be soft, they should be open. You're going to have an anterior fontanelle, you may have a posterior fontanelle. In a Down syndrome baby, you may have a third fontanelle right at the sagittal line. Look at we can do a Romberg in newborns. You look at truncal sway or loss of balance in children, newborns. Muscle mass, look at the consistency, the tone, and the strength in all four extremities and their joints. Look for any asymmetry or absence of their movements and their reflexes. After you've done your general survey of all this, then you're going to proceed with the systematic neuro exam. You're going to look at the cranial nerves. You're going to do a fundoscopy. You're going to look at EOMs and pupillary light and near vision reflexes. On the newborn, there's a general exam versus a target exam based on history or what you see. Again, you look at head shape and size, fontanelles. Talked about those. When you're looking at the baby and you start noticing minor anomalies, what's a minor anomaly? Say they had a third fontanelle. That's a minor anomaly. Say they had ear tags. That's an anomaly. Say they had polydactyly. They had an extra digit. That's an anomaly. When you see clusters of 3 minor anomalies, you want to look closer because there's probably something else going on in one of the systems. So those are just little red flags. Vertebral column, you want to be sure you palpate that. I said caution in the delivery room. If you ever work in the delivery room and you stimulate a baby to cry, you know, they lay the baby out on the table, he's on his back, and he's all wrapped up in everything in the sheet. Before you run your hand down the spine to stimulate him to cry, turn him over, make sure there's not a spina bifida or myelomeningocele. We've had reports of people who didn't do that and they break that sac, which is kind of gross. So just take a quick look before you do anything. These are the cranial sutures. Everybody should have an anterior fontanelle. Some of them may have a posterior, and this is where you're going to see the third fontanelle is right here at the sagittal, in the middle of the sagittal suture line. And you see that with what? Down. The neuro exam for newborn, you want to determine the present or the extent of any neurologic dysfunction. You want to monitor recovery, and it's also a prognostic indicator. When do you do an exam? I told my group, you do an exam, and if you see an abnormality, you do a more focused exam. You do more. So if the baby looks generally okay, moving okay, his state is okay, his tone is okay, there's no history of any problems, I'm probably not going to do a whole lot. If his history comes out, this was an LGA baby, 40 weeks gestation, we had to use forceps, it took a long time to get him out. I'm going to be looking for some cranial nerve injuries, especially around the face. If they had to pull and tug on him, I'm going to look for some palsies, brachial plexus palsies, Erb-Klumke's palsies. You might even look for cervical fractures. So pay attention to your history so you know what to look for. You want to assess a baby's level of consciousness. I've already mentioned if it's like 10 to 12 hours after delivery, this baby's going to be sound asleep. They have worked hard to get here. So they're going to be sleeping very soundly, and your neuro exam is not going to count for anything until that baby is more awake and alert and can participate a little bit. Look at their state, I'll talk about that, any kind of meds they're on, the timing of feedings. You don't want to go mashing on babies' bellies after they fed. They'll throw up on you. And you don't want to do an exam before they're feeding because they're screaming and they're not going to listen. So you have to time it just right in your feedings. And then evaluation of the selected cranial nerves. There's 3 levels of consciousness that best correlate with outcome. You have hyperalertness. This is when they're very sensitive to stimulation. They have wide open eyes, but they have a decreased blink reflex. And their decreased ability to fixate and follow. I would see this in a baby that was probably hypoxic during delivery and at birth, and they go through a hyperalert state. Lethargy. These are babies that are more obtunded at birth. They respond to tactile and noxious stimuli, but it's delayed. And how do you elicit a response? You rub their sternum. That works on babies just as it does on adults. Stupor. They will respond to noxious stimuli. And a coma, there's no response to anything. They're just completely out of it. Look at their activity, their state, their tone, and their posture. You first look at this when they're in a resting position. You know any spontaneous positioning, like if they're in a frog leg position, or their tone, they're just a wet noodle. I mean, you can pick up their arm and it flops back to the bed. Look at the symmetry of their posture. Do they have a cortical thumb? If you fist your hand, it's normal for the thumb to be on the outside of your fist. Babies that have neural problems, seizures, trisomy, they're going to fist like this. Their thumb's going to be curled under their fingers. And I've always seen that in newborns with seizures. You just look for it, and it's an abnormal symptom. State, are they sleeping? Are they quiet alert? Are they agitated? Are they crying? What state are they in? Symmetry of movement, seizures, jitteriness, and tremors. Had a friend that always says that everything that jitters is not a seizure. They can be jittery just because they're normal newborns, and they're still learning to organize everything. What do seizures look like in a newborn? They can be very subtle, they can be very overt. Then have you seen seizures in a newborn? Can be lip smacking. That's not normal. You think they're hungry, but they're not. They do it all the time. It can be repetitive movements. They can blink, repetitive blinking, bicycling, a major seizure. Sometimes they'll bicycle their leg, tremors of the arm. If it's jitteriness, you can stop it. If you hold that extremity that's jittery, it will stop. If it's a seizure, it won't. What's their tone when they're resting, when they're passive and active? And then we have these nice Ballard and Dubowitz assessments that you can use. And this is the neuro part of the Ballard. The Dubowitz is more complex. But we do this when we're wanting to check gestational age. And once you get used to it, you probably don't need the sheet in front of you. You will do it in teaching institutions for sure. Want to talk about state. This is awake and alert. This is obviously sleeping. And I just thought the puppies are really cute. They're kind of mirroring the infant state. Reflexes should be present, symmetric, and reproducible in the neonatal period. They gradually disappear during infancy. Your primary reflexes are suck, grasp, stepping, and moro. If you have a baby that was severely hypoxic at birth, APGARs of 0, 1, and 2, they're probably not going to have these reflexes. They're not going to have a suck, they're not going to have a grasp, they're not going to have a stepping. You know what a moro is, you've all had that. One of the med students or interns in the nursery decided to do a moro on his baby, and you know the textbook says they'll startle to a loud noise. He went up and slammed the side of their incubator. Well, not only did that baby have a moro, every baby in the line had a moro, including all of us that were working there. What did you do? Don't elicit a moro that way. Okay. Tendon. You can check biceps, knee, and ankle reflexes. They should all be present after 33 weeks gestation. To check tendon reflexes, DTRs on a baby, just use your finger. You can use the edge of your stethoscope. Don't use your hammer. It's too much. Clonus. It's normal to have 1 to 2 beats of clonus when you visit your foot and your ankle. You pick it up, and clonus is their foot kind of respond this way. If they have 10 beats or more of clonus, that's abnormal, and there's something going on. The cranial nerve assessment, for the eyes, you look at their fixation and following, the pupillary response, doll's eye, look at hearing, vestibular response, suck and swallow. How do you check suck and swallow? Put your finger in your mouth. They suck on it. How strong is their suck? Test for a rooting reflex before you do that. Lightly touch the corner of their mouth. They will turn to that side. Have you ever heard of a Brazelton assessment, or have any of you ever done a Brazelton? This came out in the late 70s, early 80s, and it was a neat way to show what the newborn full-term infant could do, and it's a way to promote bonding with the parents. One of the Brazelton things is showing how the baby will fixate and follow. Use a bright flashlight. You start their head in the midline, move it to one side, and the baby will follow it. Start in the midline, move it to the other side. Then hearing. The baby's going to know his mom's voice because he's been listening to it for 9 months. So start the head midline. Tell mom. Say something to your baby. And when mom speaks, that baby turns his head to her. And their faces just light up. Oh, my baby knows me. Great thing to use if you're working with mom. Pupillary responses, you know how to do those. It's the same in the baby. Are you familiar with the doll's eyes response? For a doll's eyes, you hold the baby. I was going to bring one of my babies, I forgot. You hold them, they're swaddled in your nursery blanket. But you hold them upright, about this far from you, and you turn this way, and you'll see their eyes go that way. And I know when you get in clinical, you will probably be in the nursery, because you'll have to do some newborn exams as an FNP. Check suck and swallow. For the optic nerves, I'm going to go through these real fast. They should blink in response to light. They should fixate on an object. Remember, their vision is real blurry at first, so only about 19 centimeters from their face. It's not very far. But fixate on something in front of their face. And like I said, they follow with their eyes and turn their head from the midline. You can't expect a newborn to start with their head turned to the side and come back to the midline. They don't do that. So position in midline and watch them turn to either side. The fundoscopic exam is going to check cranial nerves 3, 4, and 6. You also want to rule out cataracts that goes along with galactosemia. Check their pupil response. That is present by 28 weeks gestation. It should be pretty consistent by 32 weeks. An unequal response is abnormal in an infant, just like it is in an adult. Doll's eye maneuver, that's present by 25 weeks. The trigeminal nerve, nerve 5, you want to elicit the corneal reflex, elicit sucking and the ability to bite down on an examiner's finger, and they will bite. Facial, you want to observe the symmetry and movement of the face at rest and during spontaneous and elicited movement. You're going to see, if the child has been a forced delivery, they can have Bell's palsy. So which side of the face is going to move when the infant grimaces or cries? The one that's not affected. Okay. Response to a sudden loud noise for hearing by 28 weeks, or they'll alert, if they're in a quiet alert state, they'll alert and they'll turn toward the sound. If they fail to do this, then you'll need to go on and do more hearing tests. And every newborn gets an evoked potential before they're discharged. Facial nerves problems, evaluate rooting, sucking, swallowing, and gag. I do not usually evaluate a gag reflex unless it's a baby that's been extremely hypoxic and other reflexes are down. Okay? Because if they have a good root, suck, and swallow, they've got a good gag. In an older child, level of consciousness is probably the most important part of the exam for the acutely ill child. You want to observe their neural developmental progress and skills. Look for delays in normal growth and development. The Denver Developmental Screening Test is going to help you do this. It has little things listed that they should do. When you're testing cranial nerves, you want to modify your exam and play with them. Again, you're going to be able to see a lot just by their actions and their play. Deep tendon reflexes, you only test if it's indicated. But if the child is demonstrating appropriate responses and activities, you don't have to bother with it. Gait is always an essential test in a medically stable patient. If the kid is sick, you're probably not going to do it. But gait test for midline cerebellar function, it's a great test for weakness. Watch the arm swing, the hip movement, the broadness of the gait, and heel strike. Now, if you have a toddler that's just learning to walk, what is their stance going to be like? They're going to have a very wide stance, right? Gives them stability. And how do they walk? They kind of walk like that too, don't they? Okay, that's normal. If you had a 6-year-old that was walking like that, would that be normal? No, they should have passed that stage. Few hints, if you're asking a child to walk and look at their gait, have them walk towards their mother. They're more likely to go to their mother than they are to you, and you can watch them walking away from you. If they're old enough to do heel walking, have the child walk towards you. This is going to show if they have any upper motor neuron diseases. Toe walking, again, if the child's walking away from you. Have them walk to mom and have them walk on their tippy toes. Tandem walking. Running, including rapid turns, is an even better test. You play ball with them. Older children can do the regular test that you would do on an adult. They can identify smells. They can identify letters or shapes, maybe colors. They can certainly follow light or your finger. They should be able to identify sounds. They can identify different tastes. Have them bite down, have them chew, have them show their teeth. Older children can do all of these things. Same for the vagus, the accessory, and the hypoglossal. The best screening test in a Pedi neuro exam, again, is mental state, their level of consciousness. Cranial nerves, look at their eyes, do your fundoscopic exam, their extraocular movement, pupil response. Motor, look at drift and triceps for upper extremities. Dorsiflexors and everything for lower extremities. Do deep tendon reflexes on the older child. Cerebellar, they can do the alternating rapid movement, and again, their gait. The pronator drift is important. It says use this test all of the time. The child extends his arms palms down and his eyes are closed, and a few seconds later he turns his arms palms up. During the turning of the palms up, the child with the upper motor neuron may pull his elbows in, like that. Observe the arm position when the palms are up. The eyes, keep the baby's eyes closed, the child's eyes closed. Look for any asymmetric pronation, drift, or finger flexion. And if you ask them to shake their head no while they're doing that, that may elicit some of these responses. Manual motor testing can be done when the child's about 5 years of age. And again, like with an adult, if muscles are at a mechanical disadvantage when they're stretched, that's when you can best detect weakness. Level of consciousness, I keep saying this, it's the most important part of the exam. Sometimes these are the first manifestations of a problem. You know, a great way to awaken people, I never thought of this, is to get them upright. This works for adults as well as kids. And even babies, if you want them to alert, if you pick them up vertically in front of you, they're probably going to open their eyes. And reclining patients are ready to sleep. Describe level of consciousness. Describe what you mean by lethargic, because that means different things to different people. You can use a sentence to describe what you saw. What was the patient's activity as you entered the room? Were they resting quietly in mom's arm? Were they sitting quietly on the exam table? What kind of stimulus does it require to get the patient's attention, to awaken him? Calling a name, pinching, noxious stimuli. What's the best mental state that you saw? Were they talking with you? Were they very sluggish in their response? Semi-purposeful movements. Describe what you see. And then what happens when you stop stimulating them? If you're rubbing a sternum to get a response and they respond by opening their eyes and crying or something, when you stop, are they immediately obtunded again? It's always important to listen to the mom. I can't stress that enough. Mom knows her kids. And she knows when something is wrong. She may not know what is wrong, but she has that gut feeling that something is wrong. So, is your child acting like they usually do? Is something different? And it's okay to assess the child is sicker than the mom feels, but it's not okay for you to blow her off. If the mom thinks something is wrong with this infant, check it out. Okay? If you are working in a hospital setting and the nurse at the bedside tells you something is going on with this patient, they don't know what, listen to the nurse. They're at the bedside. You're not. You're just going in and making your rounds. Okay? Orientation. Usually this is orientation to person, place, and time are lost in the opposite order. So they're going to be confused about time, then they'll be confused about place, and lastly they'll be confused about person. When you chart, I think I said this before, avoid saying cranial nerves 2 to 12 are intact or within normal limits, which like I said means we never looked, but document what you observed. The fundoscopic exam, you're getting better at this. You're practicing a lot on your own. How many of you are practicing on your kids? Are they pretty cooperative? No, sometimes. If you're having trouble finding a disc, I like this, don't despair. First, the examination of the fundus is important anyway, so you look for retinal hemorrhages. Be patient. If you get a brief and incomplete look, just wait till the child turns back and focuses again and look again. When you find a vessel, just follow it. If it's getting smaller, you're going the wrong way, so look the other way. Otherwise, all vessels lead to the optic disc. And again, like these new skills you're learning, it's just going to take practice. Not going to spend a lot of time on these. And I may post a little Word document for you later, probably by Friday, to go into some of these. But abnormalities that you may see in newborns, seizures. Again, they don't just happen out of the blue. What was their maternal history, their delivery history? If this was a baby that got stuck and they couldn't get out, had to be resuscitated, had very low Apgar scores, you're going to have a very high index of suspicion for seizures. You're going to watch for them. Baby seizures can be caused by hypoxia. They can be caused by hypoglycemia. Years ago, when people were into these natural births, delivering at home and all that without a midwife, this mom did deliver her baby at home, and it wasn't doing well. It wasn't eating well because babies don't eat well when they're born. Finally, they got it to the hospital, and its glucose was 0, and the baby was 2 days old. That baby did end up with irreversible brain damage because, and just seizures. It was just horrible, but you know, there's some things that you just need to do for babies, and that was one of them. Germinal matrix hemorrhage and interventricular hemorrhages are something we see commonly in preterm infants. In your practice, you may get a baby that was a preterm, say a 27 or 32 week or something, and the history will be they had an interventricular hemorrhage. They're graded from 1 to 4, 4 being the most severe. What is an IDH? It's like a stroke in a baby. So they're going to have sequelae, they're going to have neuro problems, muscular problems, probably have hydrocephalus. Congenital malformations that you see, such as...
That's common in preterm infants?
The younger the gestational age, the more likely they are to have some kind of an interventricular germinal matrix hemorrhage. If it's a grade 1, it's nothing to worry about, and they generally grow up and do fine. They may not be really good at math, but, you know, not all of us are. Arnold-Chiari malformations, Dandy-Walker, those are things that have to do with hydrocephalus, the way the spinal fluid drains. You may or may not see these. Craniosynostosis is something that you might see on your newborn exam, and I'll probably cover this again next time. But you know when the baby's born vaginally, those sutures are going to override, right? The little conehead babies, you remember that from your OB experience week? Okay. When you palpate those sutures, you want to feel the ridge. Normal sutures are going to give a little bit. And there's going to be an abrupt drop-off between the plates. Craniosynostosis is when the sutures are actually fused. And there's going to be a ridge, but it's going to be a fixed ridge. How many, you want to describe how many of those sutures are fused? And these babies, I've had some that all of them were fused, and they didn't even have just a fingertip front nail. All they have. What does that mean for the baby if all these sutures are fused? Their head's not going to grow, their brain's not going to grow. So these need to be referred to a neurosurgeon, and they will actually take a saw and saw those sutures open. Birth injuries, again, you're going to depend on your history from the delivery room. If you're doing a newborn assessment, what kind of delivery did they have? Was there any trauma during the delivery? Always look for your large for gestational age babies. These are the babies that are 9, 10, 12, 14, 16 pounds at birth. They're huge. They're like little sumo wrestlers. They're more likely to have injuries because it's so hard to get them out. I had a baby with a fracture of the C5. And when I picked him up in the nursery, he was 8 months old. And he was basically paralyzed from the C5 down. And the story was he was a breech delivery. The doctor refused to do a C-section. No, he wasn't breech. He was head first. But he pulled him out, and as he pulled him out, he just really twisted him, and the baby ended up with a fracture. With all the immediate signs, he couldn't breathe. They had to resuscitate him, and it's just a shame. You know, why did you do that? Mom was a small Asian woman with this humongous 12-pound baby. But those are things that happen, so you look for them. Facial nerve palsy in any kind of forceps delivery. Want to look for that. That will generally go away on its own. Forceps deliveries can also have tearing, twisting injuries. That's where you're going to get your brachial nerve palsy. And they may or may not go away. They may require further treatment. What else? Phrenic nerve injury is also associated with brachial plexus injury, but that's where the diaphragm, all of it, part of it, is paralyzed. So the baby's going to have respiratory distress. Children, headaches is a very common abnormality in children. How do you assess for headache? What are some of the questions you ask? Pain? How long? When does it start? What causes it? What alleviates it? What other things go on? Children can have migraine headache. So you've already had that section for your adult neuro. You ask the same type of questions for children. CNS degenerative disorders, when you get into your muscular dystrophy, again, you're going to have abnormalities in growth and development. You're going to have abnormalities in your exam. I expect in your practice as FNPs you won't see these. PMPs you probably will. Trauma, head injuries, again depending on where you're working. Kids fall off of bikes, they fall out of trees, they hit their heads, what have you. How are you going to assess those? Your general neuro exam, just like you do for everything else. I included some quiz questions on here that you can go over on your own. And I don't know if you'll see these on the exam. You might. So I put the answers on there for you. Do you have any questions? I know I spent a lot of time on the newborn, not only because that's what I've been working with most of my career, but that's where you see so many of these things start. If we don't catch them in the newborn period, they're going to go on, they're going to get worse until you see them later on. Okay? Thank you.